Afternoon, Terry Shapiro, co-CEO of GIA Healthcare in Miami, Boca Raton, Chicago, Newport Beach, California, Beverly Hills, California, and 7 locations in Italy.
Well, are you phoning in from Italy? I hope.
I'm phoning in from Miramar area
Okay.
right now,
Next
which
best thing, right?
Turner sent me on a mission for it. So
Well, good to see you, Terry. Welcome. Ariana.
thank you.
Hi, Ariana Ciancio, Service Population Advocate, Delray Beach Police Department.
From the AG's office?
No.
No, not you. That's next up. That's Rich.
I don't know if I hope my mic's working. I usually have trouble
It
with
is.
it. Rich, good, excellent. Rich Worms, Attorney General's Office for the state of Florida, sitting in, listening to all the great stuff y'all are working on. We appreciate it.
Thank you, Rich. Lissa?
Lisa Franklin, Delray Beach Drug Task Force.
Jan?
And Southeast Florida Recovery Advocates and the Board of Directors for the Health Council of Southeast Florida. And a bunch of random other things.
A kick-ass advocate. Well, that's how we'll refer to you. Jan, how about you? Jan Tillman?
Good afternoon. I'm Jan Tillman, Tri-County Manager of South Florida Opioid Alliance.
I'm going to skip the Zoom user with the flowers because that's odd. But if you want to chime in, if you know that I'm referring to you, Zoom user.
I think that's
Okay, no, I don't think so. Dr. Simonidis?
I think that's.
Is that you, Doc? Oh yeah, it is.
Yeah, it is.
See, there you were. You weren't there, and now you're there.
Hello. Hi, Dr. Spinidis here. I'm the president of Florida Society of Addiction Medicine.
FSAM, thank you. And Sharon?
Thank you.
Okay, Sharon Dodrell? Okay. Dr. Needle?
I'm glad this is being recorded. I feel like this could be a spoof video with all the Zoom issues. So Dr. Rachel Neal, licensed psychologist and business and clinical consultant to substance use disorder treatment centers.
Thank you. You know what? When we get to the end of all this, I'm going to say thank you all very much. We're out of time. Tyler.
Yes, Tyler Site, Senior Outreach Coordinator with Oxford House in South Florida.
Okay. Welcome, Tyler. Is this your first meeting? I don't remember you being on before.
I've been on quite a few level.
Oh, okay. All right. All right. That's my attention span, I guess. Tom Baird.
Hi, Tom Baird with the law firm of Jones Foster in our centennial year in Palm Beach County. And I primarily represent municipalities in Palm Beach and Martin counties.
Thank you, Tom. Houston.
Hey, good afternoon, Houston Park. I'm a subcontractor for Florida DOH for their core program and mobile integrated health, and also with Southeast Florida Behavioral Health Network.
Thank you, Houston. And by the way, Houston and Tom, charter members back in July of 2016 on the task force. Back then, we were called the Sober Homes Task Force, and we actually we had 2 different groups meeting each month. There was a lot to do back then. Okay, Mike McKeel. Oh, we already did you. Okay, you've already, okay.
Come on.
We'll move on to Micah.
Micah Robbins with FAR and ditched the computer, went to the phone. We lost went to fix everything, lost everything. So back on and we'll go from here. But hey, I'm not in a car for once. This is great. And with me is Angie Sweeney. She is joining us as our Director of Appropriations and Grants. And there she is right there. She's an all-star and looking forward to talking about some of that initiative today in our report.
Excellent. Yeah, Micah, you'll be doing the FAR update for sure.
That's correct.
Matthew from Southeast Behavioral Health Network.
Yes, sir. Matt Klakowski with Southeast Florida Behavioral Health Network. Nailed it.
Nailed it. Okay. All right. Next is WK.
Hi, my name is Wissam Corey. I'm the Associate Vice President for Communications and External Affairs for the Healthcare District of Palm Beach County.
Okay, thank you. Anthony?
Hey, I'm Anthony Poto. I'm one of the network integrity managers with Southeast Florida Behavioral Health Network.
Okay, I think that's Anil.
Good afternoon, Anil Pandya. I'm the Chief Operating Officer at Health Council of Southeast Florida.
Thank you. And next would be Juan. I got to unmute, sir.
Lauderdale Fire Rescue Community Outreach. Thank you.
Okay, great. Who's behind you?
I know, bad thing. I'm trying to park. I'm sorry. Doing illegal stuff over here. I apologize.
All right, no worries.
All right, thank you. Bye.
Oh, Ken, you just popped up. Ken Shepke. Welcome.
Thanks. Good afternoon. Dr. Ken Shepke, Deputy Secretary for Health.
Next, Harbin Martha. Okay. I'm doing everybody today. Usually I just do members of the task force, but okay.
I couldn't get off mute and get my camera going in time. I'm Martha Harbin. I'm an Assistant Secretary of the Office of Quality and Innovation over at the Department of Children and Families, and my team includes the licensing team that license substance use disorder clinics.
Awesome. Well, nice to meet you, Martha. I don't recall you being on a call before.
I've been on the last couple, but usually kind of in a listening and learning mode because I'm relatively new to my position.
Okay, well, welcome.
Thank you.
And Jessica.
Good afternoon, Jessica Durant, also with the Department of Children and Families. I'm actually with the Office of Substance Abuse and Mental Health. I'm the Human Services Program Director in Southeast Region.
Okay, thank you. Thanks for being here. John Hulick.
Hi, Al. John Hulick, Palm Beach County.
Well, come on, there's a little more than that.
Whatever you want to call me, Al.
Well, you're the chief cook and bottle washer for the county, man. Okay, John is I'm going to call you drug czar, but that's not what you are. I know, but as far as the county is concerned, you're the person that's on all the meetings. You're the person who's trying to get everything done with regard to the county being involved and being productive. So thank you for that, sir. Alton Taylor. Alton.
Alton Taylor, CEO of Drug Abuse Foundation.
Nice to see you, Alton, and Maureen Killian. Maureen has been with us since the very beginning in 2016 as well. And go ahead, Maureen. Tell us who you are.
Maureen Killian, leader of Southeast Florida Recovery Advocates and parent advocate for decades.
Yep, for decades. Sharon. Oh, do we already? No. Did we already? Yeah, we did, I think. Okay. Oh, Nancy McConnell. Some mutual friends ran into you in Belgrade, I think.
Yes, I met your beautiful wife. This is Nancy, CEO of Rebel Recovery, and I'm currently driving back from Belgrade right now from our office out there.
Yeah, Nancy,
nice to be on.
You just opened up a new facility in Belgrade?
No, it's been opened up, I think,
April.
under a year.
Okay,
I
but
can't
I
even
know,
remember the date that we opened it.
but I know you all got an award this week from the Belgrade Council, and congratulations.
Oh yeah, we got a proclamation for Recovery Month. We also got one from Pahokee, and I think we're doing a couple recovery events out there this month. There's a lot of events from both sides in West Palm Beach and Belgrade.
Well, you guys have your presence in Palm Beach County, and you're doing a great job. So thank you for that.
Thank you.
Mika Hamby. Now, Mika's just sitting in observing because she's from Reuben Turnbull. But welcome, Mika. There you are.
Hi, I'm Micah.
Micah, sorry. Okay.
Fantastic name.
Okay, now I'm confused. Okay, we've got Nancy, Oh, Becky Walker.
Good afternoon. I'm Becky Walker. I'm the Chief Operating Officer at Southeast Florida Behavioral Health Network.
Thank you, Becky. Stephanie.
Stephanie Thompson, COO, Drug Abuse Foundation.
And the other Stephanie.
Stephanie Barajas, OD2A.
Hi, Stephanie.
Hi.
Ann Berner.
Good afternoon, Ann Berner, Southeast Florida Behavioral Health Network.
And we'll be presenting today about the good stuff that's coming through now.
Absolutely, thanks, Al.
Okay, Michael from the FAR board, Michael Schlossman.
Hey, everybody. Michael Schlossman, CEO and Chief Legal Officer of FAR.
Hi, Mike. Uta.
Hi, everyone. This is Uta Gatsiev with the Florida Behavioral Health Association.
And Austin.
Hello there, Austin Wright, Director of Syringe and Harm Reduction Services at Rebel Recovery.
So were you out in Belgrade to get the award as well, or the proclamation?
No, not today. I actually had a training I had to do with the Lewis Center this morning.
All right, Leah Bigelow.
Hi, everyone. I'm Leah Bigelow, the Executive Director of the Recovery Research Network Foundation.
Thank you. Natalie Kenton, you're also with OD2A. Hi, Natalie.
Hi, Al. Good afternoon, everyone. Natalie Kenton, OD2A, Department of Health.
And Amanda Busman.
Amanda Busman, Southeast Florida Behavioral Health Network, Director of Network Integrity.
Hi, Natalie. I think that's everybody. There may be one or two people who signed on late, but let's get started. As I said, it's going to be a shorter program because Dan Lauber was scheduled to do a presentation on the changes that we are working on to all residential community residences in Florida. But that's going to have to wait. It'll be next month or the month after when we'll actually probably have something in writing, some actual legislative language to discuss. Going to do a quick update on the numbers. First, the Palm Beach County Medical Examiner's Office. We try to do updates throughout the year and compare them to the previous year. The good news is I can tell you that we're at or below last year. If you look at this slide and you look at the second grouping, it would appear that in 2024 through September 10th, that we're 26% below. I wish that were so. But if you look to the middle line of that grouping, the OD deaths that are due to opioids are 57% of the total OD cases. Well, that number is probably wrong. We have the 2023 numbers, which is above. And if you look at the middle line, total opioid OD deaths, and that's no pending cases. So we know those numbers as of September 10th. 78% of total OD cases. So my prediction is that the numbers are a little skewed right now. There are 84 pending cases. We won't know for sure the exact numbers until about 3 or 4 months after the turn of the year. But based on these numbers, I can say it's going to be at or below, even at the 78% of opioid ODs to total OD cases. It'll be at or below last year's numbers, which is great. Every year, the past 4 or 5 years, we've been going down. Last year, we went down 6% from 2022. I believe the year before it was 14%. We're no longer the most deadly county in the state of Florida. I expect that the Florida State Medical Examiners through the Florida Department of Law Enforcement, their numbers usually come out close to a year after the turn of the new year. So the 22 numbers have come out. The 23 numbers should be coming out at the end of November, early December. That's my guess. Last year they came out in January. But anyway, we'll know more what the 23 numbers were around the state, but I know we were fifth lowest, well, no, fifth highest rather. And for years we were number one. Okay, next slide. Fire rescue has been doing fewer transports. This is Palm Beach County Fire Rescue. It's represents about 50% of fire rescue in Palm Beach County. We have a lot of municipalities with their own fire departments like Boca, Delray, Riviera Beach, West Palm, that kind of thing. But about half of the transports, the ones that are suspected overdoses, if you look at the 24 numbers, we've dropped 21% in transports from 2023. That's phenomenal. It means two things. I mean, number one, there's more Narcan out there. I don't kid myself to think that there aren't a lot of overdoses, but it also means in likelihood that there are fewer overdoses as well. We're down 66% gross numbers in transports, and this is number of patients, not the number of calls. I think that's reversed. I think the number of calls is the first number. Oh, no, I'm sorry. It's the number of calls, yes. We're down 66% since 2017 when numbers were being kept on suspected opioid transports to hospitals. Okay, those are my numbers for Palm Beach County. Now let's move on to FAR. Micah, you want to give us an update on beds, on units? We're gonna put you up here on the board.
Really quick, just a quick question. Is that 5? We're still number 5 in the state for per capita, for population, or absolute numbers?
We have 20, I believe 25 districts in Florida.
Mm-hmm.
It's not per capita, it's per district. So for example, the highest number of opioid deaths in 2022, the last numbers from the state, was Pasco Pinellas County, and they had over 700. Palm Beach County, I believe we had 406, something like that. Broward County was higher than us. Jacksonville was higher than us.
Okay, but it's by absolute number.
But it's by
It's not per population.
It's
Okay,
by
thanks.
district. So whatever the population is in that district, there are some districts that per capita would be higher if you looked at it that way.
Okay, thank you.
Hillsborough is one of them. Okay, go ahead, Micah.
Sure, and the housing catches up with us as we go. So this is coming through July to August 1. We'll have the further numbers on our next meeting. But right now we are at statewide 1,000, as you can see, 1,942 units with well over 9,000 beds, 9,501 beds at level 1, 2, and 3, 1,050. 5,894, and a level 4s, another increase there of 892 units with 3,604 beds. Locally, if we're keeping it local, of course, we are Palm Beach County, by far still the largest of certified units and certified beds at 3,585 certified beds here in Palm Beach County. And running second place, of course, is our neighbor to the south with 615 units in Broward County, 2,821 certified beds. And as you go around the state, again, other pockets have higher. Hillsborough, for example, Tampa area, and that neck of the woods is probably our second largest concentration after South Florida. We continue to trend up. And as you can see through go to the bottom of our FAR list here, we have the yearly trends there, but now we get down through the first parts of 2024. We look at the latest trending there. We had a couple losses and a couple gains, as always, and right now we're in process of certifying several more that are in application right now. We've actually had an influx of certification applications in the last couple of weeks, which we are processing as appropriately and as quickly as we possibly can to bring more capacity on board. Palm Beach County, which is very obviously.
Micah?
Yes, go ahead.
Let me just ask a question or
Sure.
comment on what you've already given us. Number one, so everybody knows, are these numbers as of July, the end of July, or are they as of September?
These are end of July reporting for the September meeting. So we have some in progress right now. So these will have some updates, but this is accurate for right now.
So if you would, when you get it updated to September, would you send it to Mary Ann so we can send it out to everybody?
We'll send it right along. Yes.
Okay.
Like I said, the numbers catch up with us.
Good.
But for right now in Palm Beach County, as you can see, we are, this is still the largest county for certified housing by far. And as you can see that we certify very few level ones. Our friends over at Oxford House are more in that space, but we do have a few level one programs before those. Level twos, and we'll discuss, maybe not on this particular call, but moving forward with the new clarification of the state statutes on the levels, the FAR levels of care, is that we're probably going to see a larger influx of level twos turning into level threes. But there's more to that to come. But right now, level twos, over 1,700 beds there. Level threes are kind of a small number still at 120, but of course we have a lot of level 4 programs with PHP day night at 1,682 beds.
Okay, Micah, can I back up just a minute based on
please do.
Based on the question that was asked, and if you could scroll back up.
Yes.
We've had this discussion before. Keep on going up to the various counties. We've had this discussion before, and I think you're going to address this in your update. When you talk about per capita, when you talk about population, okay, you can look at various counties and see who the largest counties are, and then you look at Palm Beach and Broward. We are two of the larger counties in the state, but you also have Jacksonville, you have Miami-Dade. There are other similar counties, and they lag way behind in terms of the number of certifications. And I know that's something that you're probably going to address in terms of your outreach. But when you look at Duval County, for example, there are 47 units, 310 beds. What's the population of Jacksonville? Like 1.5 million, like Palm Beach County, something like that.
In Jacksonville, just over 1 million people, and remember, Duval is Jacksonville.
Right. And my point is that there's a lot of work to be done around the state. Now, I know that historically, Palm Beach County especially, and Broward County as well, are hubs, if you will, or meccas for people seeking treatment in this space. It has been for 40 years. So it's understandable that we would have more providers, more component licenses, and more recovery residences. But I think one of the big efforts that need to be done, and I think Micah, you and Michael Schlossman would agree, is to get everybody educated around the state so they start to conform to the best practice, which is certification through FAR or Oxford House. So I just wanted to raise that because of we are talking counties here, but Flagler County is one thing, Duval or Miami-Dade is another. So
and Al, what a great segue you've given me. So that'll get me into the as we pass the guitar around here. Real quickly, I just wanted to give the update, and we do have the through August on the overdose numbers right here. I did want to make sure we gave that in housing, okay? And we had a total of 9 overdoses. This is in certified recovery housing, 7 males, 2 females. Unfortunately, we had 2 deaths. And both deaths were in Delray Beach. Of course, those have been addressed with our committees and with our team. But I did want to, because I don't want to take away any of the reverence to that number. But as we look at what you just said, and if you look up back here at this county information, and it's not only, again, take your flaglers, et cetera, but what we've been doing is researching around the state, not only with our DCF partners and looking at component licensing, but also just complete dead zones of recovery supports, recovery housing, et cetera. We have a huge span that, down the central piece, really from like Apopka all the way down to Sebring, which is basically devoid of a lot of pieces. We've been already out to Winter Haven, Bartow, Haines City area. Have done presentations there. We are getting around the state. We already started that process before our appropriation was approved. Our appropriation was approved just about 2 weeks ago. And the bulk of that is for education and outreach. So we have created an education and outreach team, obviously bringing Angie on to help us quarterback those efforts as we move around the state. And it is to educate not only folks that are looking to provide housing, but community leadership and first responders, zoning, development, all those individuals that are part of this housing network. We're going to be getting around the state and doing these formal trainings and following up on all the relationships we've been building in the last several months. And we're starting to see turnaround in that. So in parts of the state where we can work with providers that we have now to expand, but also work with folks that are wanting to come on and provide housing, and they want to be FAR certified. They know that's the way to go. It's also part of the state statute, but they also are now seeing the value proposition of being FAR certified from the support that we give, from the committees that help support the work that they do, and they're seeing the action come into play both for the positive and for the consequential. Our compliance committee has been working overtime, processing a lot of grievances, processing programs that, quite frankly, if they're not up to standard, we're making sure they're on correction plans. We are not afraid to pull certifications if health and safety is in question. Again, working hand in hand with DCF on some of those situations. Half our team right now is working on that for a couple programs right now. So these are things that we are excited to work about, bringing the whole state together to understand what certified housing is, but also the recovery housing movement. And so you should see some of those areas start to really pop. And especially in areas that have, really have historically not seen a lot of recovery services as a whole, but recovery housing in general. So those larger, as you said, Al, the Jacksonville's working very closely with their team up there. They have a great network that we now physically get on site to be a part of. Going to head up to Seminole County next week. Hillsborough, we're very much engaged in Hillsborough, that whole area, which is the greater Tampa Bay area. But one of the things that we've been talking about internally is to our south in Broward County, even though we have well over 2,000 beds, almost 3,000 beds in Broward County alone, Broward County is one of the highest concentrations of uncertified housing. So Miami-Dade as well. So in our own backyard, we've had tremendous work here in Palm Beach County, but as we move ahead, we just have still a huge concentration of housing in our neck of the woods. So we're going to really be working on that. And we're also looking just to our north in the Treasure Coast, where again, we have a huge concentration of housing and a lot of uncertified right now. So these are all under our purview. We're going to be working very hard this year to get out, literally boots on the ground, relationship building, educating, and looking forward to that. That's part of this appropriation. We'll also be collecting some data and really working hard to bring this message across the state. So we've had good starts so far, but looking forward to the year ahead with the resources we've been so generously gifted by the state of Florida.
Thank you, Micah. Are there any questions for Micah from anybody on the Zoom? Raise your hand. Okay. Let's move on. Let's move on to Oxford House. Michael.
Hello, good afternoon, everybody. Okay. Let's see. Can you all see that?
No, move it over.
We're getting there. Nope, we don't have it. There we go.
Okay. All right. So this is through the end of August. So we've opened a few since then, but we're at 215 houses across the state with 1,935 beds, 129 men's houses, 36 women's houses, 45 women with children's houses, and 5 men with children's houses. And just for the clarification, with children's house, a woman, or in the men and children's house, they can have a child up to the age of 12 live in the house with them as they're going through their recovery process. These are the locations that we're in. I believe we've added a couple since this end of August, but we're all across the state. If you look at our vacancy website, it's www.oxfordvacancies.com. It will list all of the locations across the country. You can put in the county and it'll come up with everything that is in that county. And so we're in a bunch of those areas that you guys were just talking about, Duval County, all throughout the central part of the state, down to like Lakeland, Winter Haven, Osceola County, which is Kissimmee, and areas in that vicinity. And we continue to plan to grow. We're looking at some more locations in Miami. And we haven't really done a huge amount of openings of new locations in Palm Beach County, Broward County, just because we feel like there's not a tremendous need there, and we want to be able to focus on some of the more rural areas, some of the areas that really do need housing across the state. And so that's kind of our focus currently. Since our last meeting, we've had 2 non-fatal overdoses. We had one in Seminole County and one in Brevard County. Thank God for Narcan. We did a staff training recently, and we are really focusing on maintaining the quality and training that quality within our membership, continuing to find good, affordable locations in nice neighborhoods, and really just maintaining the Oxford House model across the board, and getting and maintaining all of our staff sharing the same message, training the same thing, so that we can continue on. We have our World Convention coming up, which a lot of our focus is on that right now. It is in Orlando next month, and we're very excited about it. We currently have over 2,400 of our members across the country coming in. Over 400 of those are Oxford House Florida members. So we're very happy and proud. We're setting the record for attendance out of one state. And it's really amazing to see how Oxford House in Florida has grown to be this really substantial thing in the world of Oxford House. And we are very proud of where we've come from since March of 2019. And so, yeah, it's an amazing thing. The World Convention coming up is always an amazing event. If you have the ability to come, I highly encourage it, even if it's just for the Friday or Saturday. It's an amazing thing, and you get to really get a deeper understanding of a lot of the things that we do. That's all I got.
Michael, Dave Ehrenberg is going to be on the panel on Friday, I believe. I would have been on that panel too, but I have a tribal commitment that I can't be in Orlando. So, but Dave will be there representing, and I'm sure it's going to be a great conference. I'll get to the one next year. Hopefully, it's not going to be a conflict, but enjoy. And anybody who's going to the conference, enjoy.
Thank you.
Next up, any questions for Michael, Oxford House? Okay, next up is item number 5, which is the SFBEN Southeast Florida Behavioral Health Network update. There are several on the agenda, and Ann Berner, I give the microphone to you.
Awesome, awesome. Thank you so much. We're going to run through a couple of really important topics and provide a little bit more insight. And so presenting along with me will be our network recovery manager, Matt Klukowski. And so I think we are, let's see. There we go. All right, Matt, you want to jump in and take the next couple slides?
Yeah, absolutely. Yeah, how's it going, y'all? Let me turn my camera on here. I'm Matt Klukowski. I'm the network.
Oop, we lost you, Matt.
How about now?
Perfect.
Sorry about that. So like Ann was saying, I'm the network recovery manager at Southeast Florida Behavioral Health Network. Just to jump right in here. So So the managing entities determine the array of services that meet each unique community, each community's needs within our region, right? So Southeast Florida has always been leaders, Southeast Florida Behavioral Health Network, rather, has always been leaders in collaborating and
Matt, we lost you
my
again.
apologies. I don't know why this keeps happening. I don't know if my arm's hitting this or not. All right, let me back up a little bit. So yeah, Southeast Florida Behavioral Health Network has always been leaders in contracting with innovative services within Circuit 15. So the managing entities determine the optimal array of services that meet the needs of each unique community as pursuant to Chapter 394, Section 9082. So managing entities require that peer specialists providing services will be certified. And you can see in the chart here that there's been a upward trajectory of certified recovery peer specialists starting. I made the chart here starting in June of 2020, but to even give a little bit more insight, I have data tracking back as far as 2017, where there was only 49 certified recovery peer specialists in Circuit 15 and 19. And when we started to track the data separating the two circuits here, was in January of 2022, where Circuit 15 had 74 specifically, and Circuit 19 had 36. And you can see the upward trajectory, kind of proving that the bolstering of the peer workforce and the value of peers is inherent, and really building across network lines, specifically in Circuit 15, where Southeast Florida Behavioral Health Network was able to intercept with Nancy and Justin when at the inception of Rebel Recovery, and really start that consistent delivery of peer services in Circuit 15 with the pilot program alongside Houston Park. Next slide. And I'm glad I'm not muting anymore.
Yes.
What's that?
Easier said than done. Okay, there we go.
Yeah, right. All righty. So Department of Children and Families designates managing entities to either conduct peer specialist trainings or contract with providers for peer specialist trainings. So in Circuit 15, we have two providers that are contracted with our ME, Southeast Florida Behavioral Health Network, and each of them have their own curriculum that they cultivated themselves, being Rebel Recovery's peer to practice 40-hour peer training, and then also Mental Health America of Palm Beach County's peer career wellness, which Andy, the CEO at MHA, has done an incredible job really building that from scratch. And also Nancy and Krister with the peer to practice curriculum. It's just outstanding. I'm actually a certified trainer for the peer to practice training that Rebel Recovery created. And it really is just a comprehensive, beautiful training. And all these trainings cover the 8 dimensions of wellness. So what are the 8 dimensions of wellness, you ask? Great question. So this really builds, this is able to really build a person's recovery capital. And as a certified peer, it's our job to mirror wellness. As someone in recovery with lived experience, you want to be able to mirror that wellness to the participant that you're serving effectively. And a big part of the 8 dimensions of wellness cover physical, emotional, intellectual, social, spiritual, occupational, environmental, and financial wellness. And some of these kind of come along easier than others. I know even years into my recovery, financial wellness seems to be elusive, as it can be for many other people in recovery. But really mirroring that wellness, and a big part of my wellness today. Could you back it up just a little bit? Sorry about that. Thank you. A big part of my personal wellness today is that emotional and intellectual, and being really able to connect with individuals on that level, and being able to have them integrate those principles into their lives is a big main component of being a peer.
Well, and Matt, I think this also, the reason I like this slide so much is because, one of the things that that we're responsible for doing is helping inform and educate our stakeholders about the value and help reduce the stigma and really address why the peer engagement is such a critical piece, not just in substance use, but also in mental health. And so I think by displaying and talking about all the different education components in certification process, we help build that confidence in that really essential service that really goes a long way towards helping improve recovery and resiliency. So I thank you for going over those individually. So and then you're on a roll, so keep going. Here we
Yes,
go.
ma'am. All right. Which that's actually a great segue. So this is the process of becoming a recovery peer specialist, and kind of piggybacking off what Ann was saying, and not to boil the ocean on this topic either, but like Ann was saying, to really hit home the importance of training of the peer specialists themselves to be able to give those stakeholders that assurance that they're working with professionals, really, even though a peer specialist position, to be clear, is a non-authoritative position, right? We want to connect with the individual and meet them where they're at. At the same time, when we are being integrated in areas such as hospitals, healthcare district, for example, any area that, or even with police departments, giving the leaders at those respective agencies the assurance that we are professionals in this field, and that we are held to a high standard as covered by Florida Certification Board. So kind of going over this process here. So we want to make sure that the CRPS submits all forms and fees. Of course, when it comes to forms and fees, we want to make sure that's out of the way first. And that can also be a barrier for people in recovery. And Florida Certification Board is able to offer scholarships to people that want to be able to become a certified recovery peer specialist, but might not have that financial be able to pay those fees just yet. Have at least a GED and be able to pull up your transcripts. Again, that could become a slight barrier. But along the way, that's why someone like me is in the position that I am, and also the RCOs in the respective counties are able to walk with prospective peers along the path and help mitigate whatever barriers they might come across, right? Complete the 40-hour content-specific training covering the 8 dimensions of wellness, being peer to practice or peer career wellness that's offered locally here in Palm Beach County. Submit the 3 letters of recommendation, attest to experience to having 2 years in recovery, whether that be mental health recovery or substance use recovery as defined by SAMHSA's working definition of recovery, right? So that's kind of broad, and recovery is a spectrum, and we want to recognize that recovery looks different to every individual, and that all forms of recovery are 100% valid and respected, right? So the only endorsement that does not need the attestation for the 2 years of lived experience or recovery is the family endorsement, which you don't see too many of that endorsement. The main endorsement that we see is adult, and we're really trying to have a push for youth right now too, even though there is a bit of a it's kind of nuanced because that's the only endorsement that you can age out of. So currently right now we really want to see a bolstering of the youth endorsement. And Linda Taninga and Chris Harris, my colleagues, have been doing an incredible job in the Treasure Coast with really trying to build that youth endorsement as well. Agree to be bound by the Florida Certification Board Code of Ethics. Complete a level 2 background screening. Now, this is a very important piece, right? Again, it's kind of nuanced because number one, it does give that clarity and that assurance to any areas that peers might be going into, whether that be jails, like Rebel Recovery is in, they do the MAPS program with TRRN, integrating peers into the jail system, or in the hospitals with police forces. So just having that assurance with the leaders that the peers are screened for a level 2 background screening through DCF, and they are bound by the Florida Certification Board Code of Ethics, right? But we do understand that people with lived experience sometimes have a background. So again, that's something that we work with to be able to work with individuals to be able to try to overcome that barrier, whatever that looks like. And then obtaining the 500 hours of supervised work and or volunteer experience, providing one-on-one peer recovery services, and then passing the exam, right? And the exam is comprehensive for sure, and is really able to mirror what the peer is going to be experiencing, and ensuring that they're able to deliver consistent, reliable services to our network service providers. Next slide. Is there the next? Oh, yes, there's the peer framework.
Can't forget the framework.
Yeah, the most important part. So the framework that we're really trying to get home here, and we have a subcommittee here at Southeast Florida cultivating a peer support toolbox and this framework, and we created this as a team to really try to as a streamlined way to get peers educated and to educate the community and other stakeholders. So recruitment and education and trainings for organizations, healthcare partners, employees of network service providers, and the public, if applicable, kind of just getting them on the same page with the inherent value of peer services. Training, coaching, and certification. Again, that's kind of bolstering and adding more trainings, more consistent trainings, and in turn, having more people take it to become certified. And again, I just not to be a broken record here, but just giving the accolades where accolades are due to Rebel Recovery and MHA of Palm Beach County, because they really just did an incredible job making these trainings and making them readily available to the public for free, for that matter, to really get the community members excited and engaged to deliver these services. And then peer workforce bolstering and retention, reform, upward opportunities, salary, stuff of that nature. And a big part of what I try to pitch for the upward opportunity section is getting peers excited, because whenever I talk to a peer that might have stepped away from the peer workforce, I ask them, why did you step away? And one of the main problems that I hear from folks is, well, I got a job elsewhere making a little bit more. So, and also, you know, sometimes you get stagnant in a position. So a big part of that in my mind was integrating a position such as like senior peer, having them get excited about becoming more of a leader in a leadership role where it's not a supervisory role, but getting them integrated with local area politicians, and maybe even having them go up to Tallahassee to do a lobby day and teach them how to speak to lobbyists and advocate for money for peers, and really get them excited about that type of work. And I think that could really help retain and build the workforce and really build leaders in this field, which is what we're looking for. We're looking for high quality, high caliber individuals that are in recovery that can mirror that wellness. And how do you obtain and retain high caliber individuals? Upward movement. So peer wellness and resilience, that's a main thing. As someone that has lived experience, wellness and resilience can be elusive at times. So just making sure that peers and their supervisors, for that matter, especially non-peer supervisors, supervisors that might not have lived experience, are keen to what to look for in certified recovery peers, although not singling out. We don't want to make a token peer type situation. However, singling them out and say, hey, your wellness isn't doing well. We don't want that. But we do want peers to focus on their wellness first, maintaining stable caseloads, doing what they have to do for their version of recovery, and being able to really maintain that so they're able to mirror those 8 dimensions of wellness. And again, at the top of the pyramid here, we're looking at continued education, whether that be going for a degree in nonprofit management or maybe social work. We want peers to really look at their future and say, hey, where can I go with this? This is my career. I can use this lived experience. And so what are the goals? We want to create that system that leads with consistent delivery of peer services across network service provider lines. When you receive peer services in Palm Beach County, I want them to be just as consistent and stable as you would receive them in Hillsborough County or Duval or Dade. We want that consistent delivery of peer services in Florida. And Wes Evans with the department has done an incredible job as well, really trying to maintain that. And I've been really trying to integrate some of those ideals as well. And we also want to empower our peers in our network to expand their knowledge and experience and really become leaders in their field, right? We want to, in turn, show that recovery does work, recovery is possible, and in turn, more people obtain that recovery capital And in turn, you get more peers because more people are just in recovery and more people are living at the end of the day. The whole point is what happens when people leave the site after they get medication or after an overdose or after a traumatic event, whatever that looks like. What happens once they leave that, and the integration of the peer services really allows for that building of recovery capital, and in turn really builds that sustainability of recovery in general, and just leads to positive outcomes. So, and then also the increased availability of 40-hour peer certification trainings, and in turn increasing the workforce of peers in our network in general. So I think that kind of wraps up my portion. And do you have anything to add?
Well, just the fact that Medicaid is now recognizing recovery support services provided by certified peers as a reimbursable service. So again, going along the lines of professionalizing and recognizing the value to the behavioral health system overall, even Medicaid has come to recognize and appreciate that.
Absolutely.
All right, thanks, Matt. So now let's see, jumping back over to a couple other things. So, one of the pieces that I think Palm Beach County should be especially excited about is how far we've come from basically an abstinence-only model to really embracing the most appropriate levels of care for substance use. And so, one of the challenges that we've worked on is making sure that we've expanded, all the opportunities to include. And so, a lot of this is familiar, but kind of just reminding everyone, what's included. The other piece is we're as behavioral health kind of evolves, one of the things that's happening also is the kind of a move away from the term medication-assisted treatment, and really kind of honing in on the medications for opioid use disorder. So throughout here, you'll see me referencing the MOUD as opposed to just Matt. And it was also kind of traumatizing for Matt Kuklowski, because every time we said Matt, he kind of jumped. So it's kind of a tip of the hat to Matt, as well as we kind of embrace a more inclusive approach to some of the evidence-based treatments that are going on here in Palm Beach County. And then again, a reminder, I want to make sure that we're constantly addressing the stigma associated with the use of medication to support recovery and resiliency. We know that it reduces the risk of overdose and mortality. And if somebody's not alive, you can't treat them. It's a fundamental concept. We know that it increases retention and treatment. We know that it decreases opioid use. It does address the craving. It improves your social functioning. You're more present, your relationships obviously are more stable. And then because of all the support from major health organizations, we know that the use of MOUD is improving the quality of people's lives and addressing the issue related to opioid addiction. And then kind of blending some information about what's actually happening in Palm Beach County with publicly funded behavioral health services. We have continued to add additional providers. So we now have 2 different methadone providers in the county. We're looking at a third site with another one of the providers. So we continue to improve access and make it as easy as possible for individuals to receive the most appropriate level of care. And then also we've kind of looking at the numbers that we actually fund, because a lot of times what happens is there is a large state appropriation that the Florida Behavioral Health Association manages. And so they have contracted with a lot of the treatment providers so that they're actually able to get a better value on the medication-assisted treatments. And so that really kind of took off in 21, 22. So the slots that we were supporting, I think are more reflective of the use of multiple fund sources. And then also, as we looked at the length of time and people being able to transition because they've become employed and able to then support their own medical care. And so we've seen a lot of successful transitions, even as we see longer term use of the MOUD. And then trying to put that into quantity. What does that really mean? The number of people we're serving. And so when we went back and looked through our records, we identified the individual doses that have been supported with our network. And so we're just over almost 113,000 doses in the fiscal year for 23-24. And again, kind of recognizing the use of injectables and some other funding sources, the willingness or the availability of Medicaid also to pick up, and then also relying on the healthcare district to also help support the funding for the purchase of the medications that's needed. The other significant impact that some of the public funding has had is specifically on people once they complete treatment. A lot of times people have burned a lot of bridges, not literally, but they have lost a lot of their informal supports. And so we're really kind of helping them build from ground zero. And so part of the funding that we received through the state opioid response, which is a federal grant, is the provision of financial assistance. And so we looked at our transitional vouchers, which means somebody's completed treatment and is moving on to a lower level of care. And so those supports in Palm Beach County were almost about 400 individuals. And again, this is a kind of a last resort funding. So after they've been hooked up with any other kinds of supports or subsidies, we still were able to provide over $875,000 in individual supports, where we look at opportunities for them to be successful. So what we don't want to have happen is we start supporting somebody who's maybe not ready, and so they're not able to maintain or develop some financial independence. And so it's a checks and balance kind of system where we're looking at their employment opportunities, help skill build, and ultimately then be able to provide that financial support through our transitional voucher programs. And then it's not just the transitional vouchers. When we went back and we looked, in the last 3 years, we provided over 2.6 million in housing supports of various types, over 217,000 for transportation. We provided funding for the medication and med management, primary health care, clothing, education services, and then a lot of other incidental kinds of pieces, all with the goal of helping build recovery and resiliency skills. And so just wanted to brag about that a little bit as a big piece in helping Palm Beach County come out of the really dark previous years that Al was talking about, and how much improvement here in Palm Beach County we've seen. There was a couple other specific programs that I just wanted to touch on and provide a quick update. And this is one of the ones that we're really, really proud of. We've been working on this since 2020. We've had tremendous partnership with the Recovery Research Network, TRRNF, and along with Rebel Recovery, and then WellPath, which is the medical provider in the Palm Beach County Jail. And none of that would have been possible without the support and willingness of the sheriff to allow us to go in and actually do treatment and provide MOUD within the jail for incarcerated individuals. So it is a program that's 12 weeks long. It is completely voluntary. Judges cannot order someone into the program. It's actually provided out at the Belglade correction facility, and we've been able to kind of keep it going by having, once they complete the 12 weeks, if they're not ready to go, if they're not ready to be released, then we continue the supports through Rebel Recovery. We also then make sure we've got a discharge plan for when they do get released. And so then we've been looking at over the last 4 years, there was definitely a downturn during the 2021 year, but over 537 individuals have participated in the program. Then we're also in the process of bringing online our coordinated opioid recovery network of addiction care. So we're expecting to receive from the Department of Children and Families about $1 million in order to bring that approach about. We're actually working with HCA and their clinics to be able to refer individuals for both an induction and primary healthcare assessments, and have them link with peers. We're also looking to West Palm Beach and Palm Beach County Fire Rescue that we can help support transporting individuals that can better be treated in an urgent care clinic than in an emergency department. And so we've been working with the Department of Health and Dr. Shepke on the protocols to make sure we've got those nailed down. We continue working with the other hospitals, including St. Mary's and Good Sam's, on making sure that they've got protocols in place so that when individuals present with an overdose, that they've got a solid approach to making those inductions, and then also knowing what to do as far as handoffs and better discharge planning. And then, of course, we rely on our recovery community organizations, of which Rebel is a big part of that to get that going. So that's all underway now over the course of the next couple months. We'll be using a lot of the different intercepts to be able to catch people and help educate, help them navigate. So we'll rely on our partners at 211 to also be able to point individuals in the right direction. And then in the presentation yourself, you'll be able to click on some of the resources that are available through the Department of Children and Families and also through the federal government. Let's see, and then lastly, just kind of an update on some of the financial challenges going on within the state of Florida, within the managing entities, and kind of grading and looking at funding opportunities. So right now, because of House Bill 7021, there was an additional allocation of just over $5 million. So we're in the process of bringing additional voluntary acute beds, which would be a true increase in capacity through Neurobehavioral Health South Hospital. And then we're also expanding our system and our provider care coordination. And so again, for care coordination, we generally are looking at high utilizers of acute care, people with either long stays or with multiple stays within a short period of time, people who've just not been successfully engaged. We haven't found the right mix of supports and services. And so the care coordinators are really focused on that. And at some point, maybe in the near future, we can bring back another component on the success of care coordination and what it really entails, because it does require those individuals to think outside the box. And it really is a significantly different service than case management or even targeted case management. So we'll have some additional funding to support there. We also, there was a federal act, the Bipartisan Safer Communities Act, that we actually have gotten money rolled out through the Department of Children and Families. So we'll be adding that to our crisis response efforts. In addition to the acute care beds, there was also a statewide expansion for mobile response teams. And so just over $1.5 million was new to that program. And then there's kind of a constant stream of different fund sources that are supporting the infrastructure building for 988. And so through the state and territory improvement grant, we'll be getting another just over $600,000 to help support that. And then it kind of putting things in context, there was a supplemental block grant related to COVID, and that funding was available through September of 2025. But because of the accelerated pace that we were able to spend those funds on, there was significantly less available come July 1. And so we've been working with the department on how to shore that up and how to make those adjustments. We did expect to have some more of that funding available through this fiscal year. And so there was definitely the intent of having a glide path and slowly reduce or ultimately stop new enrollments. But we have been able to use our contingency funds of almost $6 million to make sure that we kept core infrastructure services in place. And then we've submitted to the department a request of just over $7 million on needed services that we are either in the process of ramping down or have stopped admissions all too completely. And so we're kind of waiting on what funding and how we might be able to put that into programs. So that's kind of the work that we've been doing over the course of the last few weeks. And then, and of course, we are final closing remarks always have to do with the fact that we are the managing entity and we are contracted with the Department of Children and Families. So with that, Al, those are kind of the areas that I had wanted to touch on today, and of course, I'll be happy to answer any questions.
Thanks. And before we go to see if there's any questions in the group, the mobile response for $1.5 million, that's statewide. It's not a whole lot of money.
I'm sorry, that was our. I'm sorry,
Oh,
it was
that's
11
our
million. Our portion of it was 1.5
Oh,
million.
that's excellent.
Okay.
Is there any rollout to that? I mean, one of the things I hear on a constant basis is, you can't put crisis 9 to 5. Ariana will tell you this, Alyssa will tell you this, that they get calls 2 o'clock in the morning of someone in crisis. And while everybody's moving toward expanding hours, is there anything, what do you have with regard to the network that will have, resources, at all hours? Is that part of the mobile crisis response team?
It is. They're actually, they're 24/7. So they're staffed and they're in 3 different locations in Palm Beach County through South County Mental Health Center. So we've got our 988/211, which is also 24/7, the mobile response teams. And then we also have our central assessment center at NBH North, which is right there on 45th Street. And they've been doing, and they are 24/7. So they have psychiatric coverage 24/7, and they've been averaging between 300 and 330 assessments a month that result in various levels. So it may not be a Baker Act or an inpatient, it may be a referral out. And then we're hoping that with that assessment center, on the voluntary cases, that we can take some of the pressure off of our receiving facilities by having longer stays at the NBH South, which will be probably what Becky, maybe up to a 21-day stay for really stabilizing, getting medications right. And so they'll have co-occurring capabilities, but that is a primary mental health facility, but definitely have co-occurring capabilities. And I think that's going to go a long way to help stabilizing and giving us more time for those care coordinators to come in and help provide that really effective discharge and follow-up services.
Do you have an estimate as to when these things will be coming online, or are they online now?
Well, they're basically online. We're just finishing up the contract with NBH to bring those online. So definitely by October 1st, but we actually check back in to make sure that we're moving it along. So it's cleared legal on their side. So we're expecting to have the contract signed and executed in just the next couple of days. And then we've got a plan of, kind of rolling it out, notifying, working with our other receiving centers so that we can make sure that, individuals who've had their Baker Act released but still need services, that we can get them into a voluntary hospital stay where those more intense services can be managed.
So if somebody has a crisis, say Ariana Ciancio gets a call in the middle of the night, and there's been a transport, but somebody needs crisis resources, that would be a 211 call, or
that's a 211 call to engage with mobile response.
Okay. Awesome. Awesome. Okay, any questions from the group?
I did, Al. I don't know how to raise my hand on this thing.
That's okay, Darcy. You raise your hand and you got your camera on,
Yeah.
so it's a win-win.
Yeah. No, Anne, I just had a question. I think this is amazing stuff you guys are doing. So NBH, I don't think they take youth, do they? I mean, so is there something on the horizon for youth?
That's been one of the challenges here in Palm Beach County. So JFK North continues to be our only receiving center for youth, but that is one of the expansions that we're hoping to be able to include as I think we started in December of last year, and as we roll out. So I am optimistic that in this next go around there's definitely some potential expectations, even if it is just the psychiatric assessment and being able to determine if a child does meet Baker Act criteria as maybe a opportunity to divert them from actually having to go inpatient. So, but again, that's a great opportunity for us to partner on.
Yeah, for sure. And it seems like there might be an opportunity to get funding from the state when it comes to, kids and mental health and youth, and just might be some pathways there to get funding to help support some of that as well. So, yeah, thank
always
you.
and always looking to our some of our Medicaid managed care plans also to support that. So we've got actually some changes in the MMA plans that are coming on for January 1st. So I'm really encouraged about the initial conversations we've had and the coordination, especially around children, and finding some more creative and better opportunities. And I know Jill Sorensen from my office has been meeting with the plans and doing care coordination in conjunction with the children covered by Medicaid. So definitely a need and definitely an opportunity. And we've had some conversations with the department about having some more structured beds, almost like a short-term residential program for children. So we're hoping to hear back on that as an opportunity as well. But we got our work cut out for us.
All rowing in the same
Always.
direction for sure. Any other questions, comments?
Yes, I have a quick question. Thank you so much, Ann. This was an amazing presentation. Congratulations, and thank you for supporting these community programs. It's about where those methadone clinics. I know about ARS in Delray. The one that you are talking to, where's the other one? And if you're willing to share the third, I'd love to know the location so we can start to pay attention when those go live.
Absolutely, and that's why I have my backup staff and support. I know we've got one in Lake Worth Beach.
Okay.
Which is Central Florida Treatment, or Amanda. And then
Central Florida Treatment, and it is in Lake Worth, and they're the ones looking for an additional site.
Right.
On the north side, and then we're actually doing some site visits with them, kind of checking it out. So maybe like in the Palm Beach Gardens, kind of the northern area.
Okay. And so Lake Worth Beach is open at this time, like with supplement funding, so we can send people? Okay, thank you.
Absolutely, absolutely. And then as soon as we get the other one on board, but you may recall there was a methadone license needs assessment that was released, and Palm Beach County actually qualified for an additional location. And so that's why we've been partnering with them to try to get something a little bit further north to support, all of Palm Beach County. But we will definitely, so if you have any ideas, let me know.
Appreciate it. Our patients will benefit from that. Thank you.
Absolutely, absolutely.
And I noticed that there was an 80% success rate at the MAPS program at the jail. Is there any data being collected on recidivism? And the reason I'm asking is there's another pot of dollars about preventing recidivism that might be available on a program through substance use disorder treatment that prevents recidivism. So it might be another pot of money out there. So
Absolutely.
are there any numbers? Does the sheriff keep them? Do you keep them?
We keep them with TRRN. So and we do follow-ups. So I think in putting that together, I will get another the information out that breaks that out just a little bit further. But because of that discharge planning, when somebody's released from jail, and they're ready to get picked right up. So that's been a huge piece of it, other than just being, literally a captive audience. Literally. So we'll follow back up with you and get you some, because they're really outstanding results, and it's been such a team effort. And I'm remiss in not providing more of those details, but I will get that right back out.
Yeah, my office is involved in a lot of different areas. One of them is drug court, and I know that MAPS has nothing to do with drug court, but it's those dollars that's trying to prevent jail population, and there's nothing better than preventing recidivism to lower the jail population. So
there's nothing better.
At some point when we have that kind of data, we've got some contacts and some people in DC that maybe we can make a pitch to them to see whether that can be a part of programs going forward, or any of the activities that the National Association of Drug Court group can
Absolutely
support or get involved in.
Al, can I just comment?
We've got that that numbers ready. Our board retreat is coming up in October, and so they get to see them first.
So and just put me on your calendar to, when you have recidivism data, let me know.
You got it.
Super. Any other questions, comments?
Al, can you hear me?
Belma, yes.
Yes, sorry. I just want to share, maybe that's good for to segue to a question that you had. We just applied, and we are waiting actually
any day now. We applied to HRSA for reentry grant. So we did it together with the jail. So we would have one visit with our outpatient mental health in general, not only substance use disorders, but mental health before they discharge them, to have already one visit before the discharge, like using telemedicine, so that we can kind of know when is the second appointment, that we really follow them once they're out. So maybe that's going to be kind of like nice addition to this ecosystem that we're talking about.
Right, tracking and data is huge. Nancy McConnell, Nancy, you got your hand up.
Yes, we did. It took a while to get this data, and I'm not sure which year it was from. I think it was after COVID at some point. But we did have a year's data of the people that completed the MAPS program compared to general population, people that did not have any of the services like we have at MAPS. And it did show a lower recidivism rate compared to general population. And I think Daniel was helping us with this report. So I can make sure that I can send it over to you, but I think Daniel has it too at Saartf.
That's awesome.
Yeah, no, we're definitely getting that all put together so that we have kind of the complete time period and to the extent that we can locate and continue tracking individuals that went through the program. So thanks, Nancy. We'll definitely follow up with that.
Okay, when I get that data, I'm going to reach out to Aaron Arnold with All Rise and see if maybe we can get kind of bring the two groups together and see whether that could be part of their programs as well. This is great. Thank you. Awesome.
All right.
Any other comments, questions? Okay, next up on the agenda, thank you, Ann. Next up on the agenda is Palm Beach County Healthcare District, Dr. Courtney Phillips, and we're going to talk a little bit about the Addiction Stabilization Unit update and also other initiatives.
Anne has to take down her screen.
You have to unmute, Courtney.
Sorry, I think Anne has to stop sharing for me to start sharing.
Oh, yeah, okay.
I can do that.
No problem. Okay. Can you all see my screen?
Yes.
Okay, all right. Well, I'm grateful and honored to be here as a representative and partner at the Healthcare District. As many of you know, I'm Courtney Phillips. I'm board certified in addiction medicine and psychiatry, and I'm our Vice President of Behavioral Health. And I'll be presenting today with Wiesem Corey. She's our current Associate Vice President of Communications and External Affairs. She joins us actually from the Florida Department of Health. She was there initially their Director of External Affairs and then also their Deputy Chief of Staff at the Florida Department of Health. So we're really excited to have her on board. And she'll be presenting a little bit later. I do want to also say that I have had the pleasure, and I'm going to start off with a quote, "A rising tide floats all boats." It's on my signature line. And I say that today because I feel like I'm amongst giants. We're all boats in the sea, and this group has really risen together. And I felt it was wonderful hearing what Saartf's doing, what you guys are doing for peers, and a lot of the community partners on this call. So thank you guys so much for being the great team that has helped us kind of elevate together over this program. It's also great to see that in the context of the improving data, Al, that you presented in the beginning. So we're going to talk a little bit today about different things. We have a lot of new initiatives at the Healthcare District that we want to share. But we also want to, there's been a lot of confusion about the Addiction Stabilization Unit and the Receiving Clinic at Healthcare District and how that plays into CORE, only because CORE was started out of our county and this kind of pilot program that we started and also ongoing program. So I'm going to talk a little bit about that today. So I'll begin. So I just want to start really quickly with the mission at the Healthcare District. Sometimes it's good to take a step back from 360 degrees. We are, as everybody knows, the healthcare safety net for Palm Beach County in lots of ways. And you can read our values, but the two that I really want to focus on today are excellence and teamwork. And I would share this with all our community partners. It seems like this group particularly shares those values with us when it comes to getting our community what it needs in terms of substance use care. So let's take a little look at a historical timeline. and our evolution to now. So, you know, in 2017 is when that initial pilot started with Houston Parks, Dr. Shepke, Darcy and Dr. Andrick, and myself as a provider at the healthcare district. And we had 30 patients, and it was successful with JFK Maine as our partner on the emergency room side. Since that time, from 2018 to 2019, not only were we building our internal quality metrics at the clinic and sort of perfecting our flow of patients from the ER as well as from the community, we were also in communications as an organization with JFK North to become the addiction stabilization unit that it did become in 2019. It's very important to point out there's one medical thing during that time that's very important. When those contracts and discussions were being had with JFK North, we were dealing with heroin. So if you see below, you see that we were mostly in a crisis of pills and heroin back then. Why is that important to this? That's important because to stabilize someone with MOUD, as Anne so gracefully put it, you needed about 12 to 24 hours after their induction, after their last use of heroin. And that was very amenable to the scope of an emergency room's timeframe of keeping patients and how long that they kept them. What you see is not only that, so hold on to that for a second, because I'm going to bring up when fentanyl switched and how that adjusted things a little bit, okay? So in 2019 of October, the ASU officially opens and we moved our clinic on campus with them up at JFK North. And as you guys all know, in March of 2020, we were in the throes of the initial parts of the COVID crisis, which presented challenges to all sorts of new programs. And this one was not, you know, wasn't special in that way. But in August of 2020, with all of that going on, you also had a switch over to fentanyl. So that becomes relevant for length of stay in JFK North emergency room. When fentanyl first hit the ground, clinicians, we didn't know what to do with it. We were seeing people precipitate and take a lot longer to be able to stabilize on Suboxone, okay? So where it used to take 12 to 24 hours with heroin, it was fairly predictable. This took sometimes, at that time, I remember being a clinician, it was 24 to 48 hours after their last use, which was a long time, a much longer time to get them on the medications to stabilize them so that they would be willing to hear and receive all the other supports that are used to treat this complex illness. So, and the literature really hadn't caught up at the time. So I think that's a very important timeline because that scope of time, 24 to 48 hours, is not something that's usually consistent with how long an emergency department will keep somebody in-house, right? So I think that's very relevant to this discussion. But we all carried on from 2020 to 2022. We probably saw our highest volumes that I'll talk about in our next few slides. And we got the attention of the state in April 2022 as one of many sites they wanted to visit to see what we were doing as they were seeing some shifts in our numbers, which I'll also show. In August of 2022 is when the state of Florida Department of Health and in conjunction with DCF decided to roll out CORE to the other 11 counties. We were still considered one of the 12, even though at that time we didn't receive CORE dollars. We did, we were counted in the initial 12 counties. And they were going to replicate the model that had been developed. So those are all relevant features. And then in 2023, I just want to point out that things started to shift a little bit with the unit, which I'll speak to in a second. And then at the end of 2023, operational oversight of CORE moved under DCF from Department of Health. They had been working in partnership, and now it's being rolled out to the other 17 counties. And I'm glad to see Anne is using those dollars for such enhancements to the CORE system in Palm Beach County. And we continue to basically change in that way. And then on the bottom, what you see is we've gone from about 30 patients in that initial year, which was the pilot, and now we treated 2,000 unique patients last year in 2023. The cumulative number of patients, unique patients treated from 2018 at the district clinic side, not the emergency room side. I want to say that the clinic side was a little over 3,000 patients. Okay. So, as I was kind of going through this, I was looking at some very interesting data from the Florida Department of Health charts. This is data that you all can access for free. And they don't have their 2023 published, but I know Al keeps us up to date at what's going on the local level. But it really lines up with what Al says. So if you see on the top in the green arrows, you see the state of Florida data. Okay, so you see that in 2020, 2021, 2022, you see drug overdose deaths kind of peaking in the state. And you also see an increase on the right side of Narcan administration, not only by EMS throughout the state, but also in the community. Now let's take a look at that same data if you look at just Palm Beach County. We really peaked in terms of overdose deaths in the middle of 2020. And we started declining, which is consistent with what you've been showing us for a long time, Al, after 2020, while the state was actually still increasing. You also see our Narcan administration, both in the field and by EMS, starting to sort of drop a little bit. That doesn't mean that there weren't problems, but we were seeing a different trajectory than the rest of the state. So kudos to everyone here. And it's important to recognize that this group was on the leading edge of the state for a long time, if you didn't know that. One other statistic that I found interesting when I was looking at the Department of Health statistics was pregnant women and infants with OUDs. So many of you know that when a woman is pregnant and she has a lot of withdrawal throughout pregnancy, the baby can die from something called neonatal abstinence syndrome. And this is tracked and followed by the state to see as a lagging metric, are we not only treating people, but also a very sensitive population. And you can see Palm Beach County had a peak at the same time we had overdose deaths, but we also had a rapid decrease. Kudos to DAF for their women's and children's program, Wayside. We at Healthcare District see pregnant women, and so does JFK in acute crisis. And I also want to point out one other piece of information. This study on the left, you can read it if you want to. It's from 2022, but it showed that really in a national survey in 2022, only 5% of emergency rooms nationally treat opiate use disorders with medications for opiate use disorder, MOUDs. That's very low. And I just want to point out that even to this day, in the past and to this day, JFK, which I'm going to show you some data later, still is in that in that 5% population of emergency rooms, as well as the only emergency room currently in Palm Beach County that treats patients in acute crisis with MOUD to stabilize them so that they can be open and receptive to all the other things needed. So we're fairly lucky to have them to this day. I'm happy to hear Anna's doing stuff with urgent cares, MD Now. That's very interesting, and I'm looking forward to seeing how that works. So we have more people that do that, or more providers that do that. And also in an article on the right, only 1 in 5 US adults with opiate use disorder still receive medications to treat OUD. This is important because we still have a gem with JFK North Emergency Department. And I just wanted to point that out, and they're still in that 5%. So with that being said, the way CORE is structured, and I was part of developing a lot of what ended up in a guidance document for DCF, but also the initial 11 counties, was 22 criteria. I don't want to bore you with this. If you want to read through it, you can. But I want to point out that one of to this day, to this current moment in time, Palm Beach County would meet by assessment all 22 criteria. Kudos to us, JFK, everybody in this room for everything they've done as the criteria to meet a CORE community. There's lots of communities joining that are trying to meet these criteria and using this as a guideline to set up their systems. We've had it, and we continue to have it by this criteria. And I can point out that the 24/7 access to care, we have that at JFK. If you still go, you get treated with medications, and I can show you that a little bit later. The 3 main prongs of this 22 criteria. We also have a 23rd criteria, which is needle exchange. Thank you, Rebel Recovery. Not all counties have the political advantage of being able to have that service. So the 3 main prongs of CORE are first responders involvement, hospital emergency departments, and treatment facilities that can take care of somebody for lifelong care. I put in green circles next to 2 and 3 because we have those fully. And first responders, we have an amazing program with Lauren and MAH. They do a great postvention. So I put it in yellow because it would be an amazing icing on the cake if EMS did inductions at some point, or we were able to accomplish that as a community to assist EMS and be able to do Suboxone inductions in the EMS bay. I think that would turn it green and be a good way to enhance this system. This is So going forward, this is our summary report for 2023 for HRSA. It actually encompasses all the services that healthcare district deals with: medical, dental, behavioral health, women's health. But I put in red boxes things I want you to pay attention to. So you can look at the other details if you're interested. In 2023, we had 11,000 visit types for 2,000 unique patients. On average, the patients came once a month for substance use, okay? And that grew from 4,000 visit types in 2018. And I just want to point that out because there was a lot of growth, but what you see in 2021, at the same time, Florida Charts is showing that we had sort of our peak in 2020 and starting to improve in 2021. We start to see a plateau of patients or visits coming to the clinic over the 3 years, kind of indicating, and what this means to me, and I'll show this in other data as I put all of this together, is that we're starting to meet the needs of our community in terms of substance use care. Yes, we can always improve, but these programs have and continue to, including Healthcare District JFK, meet the needs and the demand of a lot of what's going on in the community, and that's showing in the data. We also track other things. We're not just looking at their substance use care. There's lots of other factors. We do look at social determinants of health and try to work with community partners. And you can see on the lower right, we're looking at depression remission. HRSA sets it at 14% by their standard. We're at 40%. We actually are one of the top remitters for depression in that category, and we screen almost everybody for depression and treat mental health. Many of you are familiar with this dashboard, which is the Brief Addiction Monitor. It's a 17 item questionnaire that is now part of the core criteria for programs for the funding. And it tracks use scores over time, risk scores, and protective scores. We've been tracking this since 2018 with a little over the 3,000 unique patients that we've seen since then in the clinic. You might say, how come we had 2,000 in 2023? Because we've maintained a lot of those patients for many years, because it is a lifelong illness. Okay, so 2,000 was a snapshot in that year, but we're maintaining a lot of them. And we've had a little over 7,000, or around 7,000 surveys. So you see the use scores over time with these patients, the more they engage with our clinic, go down. The risk of them being around high-risk situations continues to decrease the more they engage with the clinic. And you see their protective scores, things like, do you have enough money to support yourself? Are you connecting with family? Do you have good sober supports? Slowly increasing over the time that they engage with our programs. So this is the ultimate outcome measure after the patient's out of crisis, through treatment and lifelong care. And we continue to track and follow that inside of our programs. So this is the dashboard that a lot of you guys are familiar with, and I want to point your attention to a little caveat. This first one, I actually filtered it out by 2 years period. So I looked at October from 2021, which is when we initially started doing this dashboard, to December of 2022, which was kind of the height. As you can see, and this is tracking people not in our clinic. This is from our recovery coaches who are working inside of JFK North emergency room. You can see that there's a large amount of volume and is fairly consistent at that time. 1,400 unique patients around that time. And that 59% of the patients who had opiates in their system were given buprenorphine or Suboxone in the emergency room. That's amazing, given that JFK is one of that 5%, and not only are they one of that 5%, they were giving 59% of people who met criteria that medication to get started. You also see the length of stay. If you go back to what I said about fentanyl, so this is the height of fentanyl, okay? You see the length of stay at 1, 2, almost 3 days. That's a long time for an emergency room, and they don't really keep people in any other medical condition for that long. Finally, you see about 50% coming to the clinics, and you also to the healthcare district clinic, and you also see a very low rate of people leaving the emergency room against medical advice. Now let's take a look at that same dashboard from January 1st, 2023 to August, just this last month of 2024. Now, this is when you start to, we were talking as a group, like the unit started to change to a service line, and it did change to a service line inside of the regular emergency room, okay? I was looking at this in the context of the Florida charts for a reason. You see that the numbers are dropping off. So we did start to, and this is coming to the emergency room. So what could that be due to, right? Let's raise the question. It could be due to less people going to the emergency room. It could be due to the fact in that data, and I think this is a big part of it, that we were starting to meet the demand of the crisis, not just us, but all of the community supports that have been built in terms of providing 24/7 care, as well as consistent outpatient care or rehabilitative care or whatever level of care that patient needed. That's another possibility, that there's more people who are willing, who are getting the treatment they need. You also see of those patients, you still see 51% of the people with opioids inside of that ER are still getting started on Suboxone, which is the recommendation from ASAM and evidence-based care, and still a gem for our community. And you also see, this is the final thing. In these last 2 years, the medical literature for ASAM has grown substantially around fentanyl as opposed to heroin. We've, as doctors, learned how to induce people more in 12 to 24 hours to stabilize them, and even less than 12 hours, sometimes within 2 to 6 hours after their last use. Whereas back when it first came out, fentanyl, it was taking us 36 to 48 hours, sometimes 24 to 48 hours, but right around that time period. What does that mean? Medicine advanced. We were able to stabilize people faster with fentanyl like we used to with heroin, and we were able to decrease the length of stay at JFK North, because once they were stable, they were sent to the next option. Now, and overall, you see hospital disposition for HCD during this period was on average towards 50% with some blips. We just certainly see some blips here in February. You also see in a couple other months, and I looked back at those times, and some of that had to do with some of our staffing changes. But I would say all of this together to summarize, that JFK North has served 2,515 unique patients per our data set since October of 2021, up to date, through the former ASU and now through the regular emergency room. They have shifted from a unit to a regular emergency room. The healthcare district outpatient receiving clinic has served 3,074 patients since 2018 up to this date. And we still, as a community, are proud to say that we have all of the elements of a core program per core guidelines in Palm Beach County. This does not mean that we don't have room to improve. I'm so happy to hear that there's more methadone clinics, there's more sites willing to do this induction work, and there are more partners out there, TRN, Rebel Recovery. I'm so happy to hear about the peer programs. We can always become better, but we are, and we have a lot of the core, all of the core elements in place at this time, especially even according to the current guidance document through DCF. Of course, we're going to continue to work on our improved internal quality, but we'll always improve together. So we're looking forward to collaboration. I'm excited to hear about the new funding streams and partners joining our core network through Saartf. And that's kind of what I wanted to summarize. So let's go to future directions as far as healthcare district and where we're going. So we're working on building a central receiving facility, a publicly funded central receiving facility that will serve Palm Beach County as a psychiatric emergency room that also treats all acute substance use disorders the way an addiction receiving facility can and does. So for us, you know, psychiatry or substance use is one chapter of the DSM-5. What we're training all of our teams and sort of putting out there is that it's one of many mental health problems that we need to be able to treat acutely, and they all need to be treated in one house. We're looking into CCBHC certification. As many of you know, and maybe some of you don't, we've also launched 2 pilots, one to expand our hours at our Mangonia Park Clinic. They're currently expanded Monday through Friday, 7 a.m. to 7 p.m. from 8 to 5. And we're planning in early Q1 of 2025 to add Saturdays and Sundays, 7 a.m. to 7 p.m. so that there's an alternative option to Baker Act. If someone's already needing Baker Act, they have to go to the hospital, to a Baker Act receiving facility. But if they're only going there because they need a psychiatric visit, we're going to have that in-house. We're hoping by the end of this year to be able to accept children there. And speaking of children, We have a full outpatient child psychiatrist who joined the team. He's currently working in Delray and will be moving to our new Atlantis location. We're very excited to have more outpatient psychiatry for children, and we're developing also other therapy programs around children to complement what's already in the community and school district for kids. And inside of that expanded hours clinic, we're also working on being able to dispense emergent medications in the clinic through our pharmacy licenses, including Suboxone and some early withdrawal medications, so a patient doesn't have the barrier of having to be sick and go to a pharmacy that's off-site, especially if they're not open. We also are doing the pilot with the crisis response team through PBSO. It is a co-responder unit. It complements MRT through South County is doing a great job, and it adds a layer of responding to mental health driven calls through 911 that PBSO traditionally would have to respond to. Instead, we're piloting with them to have 4 units running by the end of this year during the daytime hours to cover the 4 regions of PBSO during certain hours. So that's currently being built out and has 1 team. We'll have 2 teams by October 1st. I mentioned what we're doing with pediatric behavioral health. And that child psychiatrist, you know, as an FQHC, we can see everyone regardless of their ability to pay. So even kids without insurance or Medicaid would be able to come there. We're doing a lot of work with the Homeless Resource Coalition. Dr. Andrick has worked really well with the county homeless shelters to provide a full-time van and team that goes to all the homeless resource shelters around the county, because we also know that social determinants of health are very important in terms of health, behavioral health, and substance use care. And we're building our outpatient mental health provider team and expanding it across many clinics to position ourselves to be able to provide the lowest barrier of care first to patients needing mental health care, and then increase the levels of care from there so that we can become a full system in the future as we develop the central receiving facility. With that, and I do want to mention one other thing, we're going to be taking, we are able to do long-acting injectables for psychiatric medications for anyone clinical on this team. And we have about over 70 patients on injectable Suboxone, Sublocade, and Brixadi. Very grateful to FADA for funding that program. We utilize it, and we also use a lot of the insurances. So that product is very interesting as well. With that, I appreciate your time. And I would like to introduce Wiesem to get started.
Thank you, Dr. Phillips.
Thank you. And I will end.
While you're transitioning over, Dr. Phillips, the Suboxone injectable, is
Yes.
is that becoming the best practice in terms of, I know it's being used when people leave jail from programs in the jail. Could you just like very briefly tell us the positives and whether we're tending that way in the future rather than short supply, short.
Yes, so I'll say it's a new pharmaceutical product. I think there's left to be more replication of studies, but it's been anecdotally on the ground. I've utilized it a lot. It takes away the interactions. You know, with addiction, there's a psychological connection to taking pills. You could give someone with an addiction sugar pills and their brain would light up in the addiction pathway. To get rid of pill interaction and to have an injectable is actually very favorable towards that patient further improving their outcomes for care. It also takes a lot of transportation barriers. It's much easier for the patient to get an injection once a month or on a regular interval. So I do think it's a very interesting product. We're using a lot of it and seeing very, very good outcomes. And I'm happy to see that almost all insurances are supporting it, as well as FADA is also supporting it as well. So I do think, you know, if you're asking my opinion is that it is going to be a big future product and could become a first-line agent like many antipsychotic injectables did for severe mental illness. You might see injectable buprenorphine take a big share of the market in a good way. They are doing a study, the pharmaceutical companies, of in starting that product in the emergency room. That's not ready for practice yet. It's not posted, the results aren't up, but it's a very interesting study that's going on that I'm watching for to see if that becomes a new way of doing things, because then the person has it in their system for a month, right? So you see better adherence, you see less falling through the cracks in between appointments, and more harm reduction in terms of overdose protection. So yes, long-winded answer, but yes, it's a very interesting product that we should all kind of pay attention to going forward.
And it is, I take it, FDA approved,
Yes.
but they're still studying the when as far as best practice.
Yes, I'm not aware. I saw that someone from FSAM here is that it's officially a best practice. I can tell you a lot of us addiction people in the community are really excited about what we're seeing in the clinic.
Well,
So,
Dr. Seaman,
yeah.
are you still with us?
Al, I just had one quick question for Dr. Phillips.
Yes.
Dr. Phillips, do you use or have you developed a unique screening tool for individuals who would be better predisposed for the injectable?
Not necessarily. You know, first, I'm sort of utilizing it in practice. If somebody has the resources to support it, we try it first line, because along the same thinking that, you know, you get away from the adherence problem of taking the medications if you have it. If somebody doesn't have that, I still use the Suboxone pills. They're still kind of the gold standard in terms of starting. And oftentimes they can't just start the injectable. They still have to be on pills for so many days. So there isn't a screening tool that I'm aware of, but there are criteria that you should pay attention to. And if people have repeatedly failed in the past to manage their medications well, it's a very good product to think about early on. There's a little more accountability built in with it. It also has a longer half-life than the 28 days that it's given. What does that mean? If somebody misses their injection appointment after 28 days, they still have it in their system up to 45 days. So it protects them even past their appointment, which is wonderful in terms of overdose protection.
Great, thank you.
I noticed at Houston Park, you had your hand up. Did you have a question before we proceed?
Yes, I do. First of all, I just want to compliment what Dr. Phillips is talking about, and just take us back to when we started, because this pilot that was initiated has become known across the state as the Palm Beach County model. And so all of these new counties coming on board with the first 12, then the next 17, and they're getting ready to roll out another 17 counties, make reference to or have reference to the Palm Beach County model, which really says a lot for this group. Also to include, like, the second criteria is utilization of the peers. Because when we started this program, we went out with the peers, and I can honestly say that it was myself and Nancy, for the most part, that were going out and interacting with these patients. And if we had not had that peer specialist involvement, I really don't think we would have the notoriety of everybody looking at the Palm Beach County model, because I think that bridged the gap significantly. And then one other thing I just wanted to add is that with Dr. Phillips's work and Dr. Shepke's work, not only are these protocols written for this community, but everybody around the state and now other states are starting to look at this model and these protocols and are following what Dr. Phillips is saying as far as the induction dosages. And then one last thing, the connection with HCA, they were the original partners to play with us as the hospital provider. And they're stepping up to the plate again with the out-of-the-box thinking that we suggested to HCA management, which was to utilize some of their MD Now clinics, which may in the near future become a destination for EMS agencies to transport and not overload emergency rooms. I could go on much longer, but I'll leave it at that.
That's great, Houston. Thank you for your comments. Okay, the end of the presentation is about to begin.
It looks like you're still sharing.
Yes.
Am I?
Yeah.
Hold on. I apologize.
It's okay.
Hello?
I'm not sharing, actually. It's still there?
Yes.
I have the options to share. Okay, I don't know what I I have to reshare it to my screen. Oh, okay, hold on. I think I found it. Sorry. There you go. All set.
There we go. Okay, cool. Thank you, Dr. Phillips, and good to see you again, Houston. Like they had mentioned before, my historical position was at the State of Florida Department of Health. I served both as Director of Communications, and then subsequently as the Deputy Chief of Staff. So I'm here to talk a little bit about the history of how we replicated the Palm Beach model, just like how Houston was saying. And the path forward, as Dr. Phillips had talked about. So when we started this priority, this was a top priority across the aisle. The governor really took this seriously. First Lady took this very seriously, and their goals were lifelong care. And we were seeing constant overdoses across law enforcement, EMS. We all know this story.
Are you sharing your screen? We can't see it.
Yeah. Sorry, 1 second.
That's okay.
Is that not?
Is everything? Good.
I can share for a little bit longer. Well,
Yeah, if you want to just do that, that might be easier.
okay, let me fix it. So I got this in format for you.
Thank you. So the overall goals really were the state really wanted to find a way to give patients their life back, and they looked at overdose as a symptom, and that was really something Dr. Shepke put at the forefront, and we worked very closely together with Dr. Phillips to implement policy that really supported that. So the first step of our endeavor was to conduct site visits. And important, you can go to the next one. So the state of Florida, including leaders from DOH, DCF, ACA, and the governor's office, we visited various locations conducting substance use disorder treatment programs. All of them were monumental, but our mission was clear. We wanted to find a holistic model that supported long-term recovery and didn't treat the situation as an acute incident. So this is a photo I had taken when we were visiting Palm Beach Fire Rescue in 2022. So that was in April of 2022. If you want to go to the next slide. So this is actually a document that Dr. Shepke and I brought to the state legislature to advocate for core funding in 2023 legislative session. And it really amplifies the data behind why Palm Beach County had the best model for replication. So the long-term success rates for abstinence treatment programs was close to 0 at the time, and the Palm Beach County model experienced a 5-year success rate of more than 50%. On top of that, specifically, more than 60% of patients were on MAT. The retention rate of those patients with 2 or more visits at the clinic to retain care was at 70%. And there was an average of 2% overdose relapse rate. And that was significantly higher than any national statistics that we had. And the results were clear, the success was clear, and that is why Palm Beach County, this whole team, is responsible for being able to have that now available across 29 counties, now started with 11 on top of Palm Beach County, and then 17 on top of that. So if you want to go to the next slide. So I'd like to end on a personal note. Many of us have a lot of personal connections to the devastation that is substance use disorder. This is my cousin Andrew. His name was my first word, and we grew up we were inseparable. Unfortunately, he started using drugs and alcohol when we were about 13 years old, and for about 15 years. He was in and out of jail, homeless, overdosing repeatedly, struggling with chronic health conditions, including morbid obesity, diabetes, and a severe cardiac condition. He had severe polysubstance use disorder. He was seeking a high, It was past the point of any sort of opioid specific withdrawal. He would find anything from heroin to Xanax to hand sanitizer to computer duster. He really was a troubled soul. Until I started working on this project and I met Dr. Phillips and Dr. Andrick, and I worked with Dr. Shepke, I didn't know how to help. My family didn't know how to help. We didn't have much knowledge on what was going on. And I had helped him get into some beds at the time, but he just failed countless programs and kept relapsing. So he ended up entering the core network in Marion County. And because of that connected care model that we've replicated, his customized treatment overseen by a medical doctor helped him lose weight, placed him on the appropriate psychiatric and diabetic medications. He has a full-time job now with benefits. His felony was dropped to a misdemeanor because of the proven success that he's had showing his sobriety. And after less than a year of remaining in the connected care program with CORE in Marion County, he celebrated his 30th birthday last week with our family. And that was the first time we had seen him clean and healthy, the first time since his battle started. And that's him on the left during his active use. I don't remember a time that I heard him not sounding under the influence. And now on the right is him celebrating his birthday at the river, having a great time. And he's extremely grateful for the CORE network, and speaks very highly about it, and tries to recruit other people into the program as well. So that's the conclusion of my presentation. Just a little bit of history. And I just want to thank everyone here. Like, my personal story is just, a lot like everybody else's. This issue doesn't discriminate. And I'm just honored to be joined by so many people that are fighting the good fight. So thank you.
Thank you. Any questions, any hands? I just, we've gone through a lot in Palm Beach County over the last it was 8 years in July. We're in our 9th year. And I really want to take my hat off to Ann Berner and the crew, Darcy Davis and her crew, Courtney and Belma, Nancy McConnell for Rebel Recovery. If you recall, those of you who've been with us since 2016, there was quite an interesting individual who was in running Rebel Recovery, Justin Kunzelman. But he was as dedicated, and I'm sure he is, all of us. Houston Park. I remember every meeting, and we had the meetings every month back then. We were talking about the contract with JFK and the contract with the county forking over $3 million. And all this stuff was doable because of the efforts and the determination of everybody who's many of the people who are here in this meeting, but everybody who's been working toward that goal. Dr. Shepke, it's Ariana. I think you've been with us almost since the beginning as well, out of Delray, and you've seen it from the street level. Lissa, you and Maureen. I mean, it is a sight to behold, but we have a long way to go. With that, if there are no questions, thank you very much for the presentations.
So Al,
John, Dr. Simonides, please, you go on.
Thank you about that. Yeah, of course, we had great presentations, and thanks for Dr. Phillips and everything she does. I want to clarify about the buprenorphine. Injectable buprenorphine, of course, it is FDA approved, and it is being used out there quite extensively, actually. The major drawback, sometimes it requires some prior authorization and possible potential failure on the oral form first because of the cost, but otherwise, yes, it is approved that we use it. And there's different preparations. There's preparations that they are like 1 week, 2 weeks, 4 weeks, and depending on which one we use, it's depending on the case.
Thank you. I'm glad you brought that up because I was going to ask the question and then we got interrupted. And now, did you say something about the cost being? You didn't say prohibited, but is it very costly?
No, of course, it is covered. Most insurance companies, Yes, once the insurance company will cover it, and of course, the grants do cover it as well. So it's very effective.
Well, as the numbers,
because it's more expensive than the oral. Yeah.
well, as the numbers come in as to its effectiveness, I think, well, I would hope that that would be adopted. And costs would go down either through subsidies or through use, through the amount that's needed. Of course, I may have more faith in pharmaceutical companies than I should, and we don't have anybody from insurance companies here, so I'll leave that alone. Okay.
So Al,
yes.
can I just add something? I'm sorry. There are still
Sure.
questions in the chat about ASU. And I'm not sure if Dr. Phillips, if you can share your screen, I think I saw on the timeline something that might be helpful, because people are still asking if how ASU is providing when it's closed. So I think like the purpose of this presentation was that we talk about what's going on in ASU, and think people are still confused. So Dr. Phillips, can you go back to that timeline and kind of go back to that? I think you just brush off on ASU as a separate unit versus ER regular beds, 2023 bullets.
Right. So JFK North no longer has a unit, meaning a space designated where these patients stay. They go into the regular emergency room with other medical emergencies, and they are treated in there with addiction services by the same physicians, just in the regular medical emergency base. So there is still always patients being received there currently today who show up there, they get this life-saving treatment, and they're transferred to our clinics with the use of peers, with a warm handoff. So it's changed from a space to a service in the medical ER. It is still active and running. And as you saw from the data, 51% of the patients with opiates in their system get treatment in that emergency room.
Dr. Phillips, okay, go ahead, Belma.
Sorry, if I can also add, like during those years, many patients who are coming to our clinic doing the same word of mouth. So many people just walk in the clinic. So although you have overall numbers in Palm Beach County dropping based on everything that we've seen, numbers in our clinic are not dropping. People are using, as Dr. Phillips said, I think that was the main point of, I really enjoyed some of the points that she made, that we are addressing the crisis, we are providing the needed care, and people are going in outpatient treatment instead of emergency room when they have the moment that they're seeking help. So I think the whole purpose today, what Al asked us to present, is that we really give a status of ASU in the conjunction of healthcare district services that we are providing.
Thank you. A couple of things on that. One, I think you've hit it on the head, Dr. Phillips. Courtney, when you call something a unit, you think it's a self-contained unit, but I think one of the disconnects and one of the things that I guess needs to be commented on is between 7 p.m. and 7 a.m., if somebody is transported to JFK, are there contingencies? Are there places for them to go, or would JFK retain them until you open your doors the next morning? It's kind of a common sense question because you can only be open as long as you can be open, as long as you have the resources and can afford to do it in the staffing. But what is the protocol after 7? Or currently on weekends until it becomes 7 days?
So, I did ask, so anecdotally, I did ask someone from JFK to come. He wasn't able to, Dr. Keene. He had a prior engagement. So again, I'm not working in the emergency room or writing their protocols. They are a partner for us, a great partner, but a partner for us. And I think we're recognizing that there are those times where somebody needs to be transported. I do know anecdotally that in the emergency room, so I'm pulling up that 2023, 2024, if you look at the blue line, I know anecdotally that JFK social workers who are still there are really doing a better job also getting people into other facilities. There's been good working relationships with Mandala. When Retreat was open, it just closed. There was a lot of relationship with them for insured patients. And there's more connection through that social worker with those other facilities as well. So you're right, Al, I think that there is a gap there, being honest. And there are some patients who are, yeah, they're discharged home and then they're followed up with, but you know, I still see a similar percentages of them showing up at the clinic as before. With that being said, Al, I think it's a fair point and something that we're exploring as a group that we need to cover those after hours and have those things. So that is why we're positioning ourselves to build out to that, as well as look at a central receiving facility 24/7. If this program proves anything, it proves that having 24/7 support is so important. And Anne has those pieces. So I agree that there's some gaps there after hours to get that warm handoff immediately at the time. But I would say that the numbers show that we're still getting a good percentage of them over.
No, this is not critical. This is actually
No, it's a good question.
This is actually an opportunity.
Yeah.
Because, for example, if we have a gap, we have Southeast Behavioral Health Network, and perhaps there can be some line of communication between JFK itself after hours and the crisis. That's why I asked about the crisis units. And this is something offline. We don't have to discuss this here, but this is something offline that perhaps there's not perhaps, I believe there's an opportunity to better serve through that in that gap with other partners.
I think that's a great point, Al. I think that's a very good point.
If HCD can't do it, other partners may be able to step up, because a patient is a patient is a patient, whether they show up at Alton Taylor's place at DAF or whether they show up to JFK being transported. So good, it's an opportunity.
So there is another, I think there are a lot of great questions in the chat. So I'm kind of moderator of the chat. That's how I usually put questions. So I appreciate that. So question is, since there is no specific unit or beds and now just service line, what separates this from a regular emergency room or care that would be given in a regular ER? What separates this is exactly what Dr. Phillips was talking. Only 5% nationwide other emergency room are still providing Suboxone. This is, to our knowledge, the only one. I mean, with this a self-ban investment, we hope it not to be the only one. But in present time, it continue to be the only one. It continue to be the only one who has a peers inside. I would add to your question, Al, majority of those patients, even in the peak of the ASU use, were walk-ins. So those people can walk into the clinic, and we have 24/7 peer service. So even if they come on weekend or after hours, they're connected to our recovery coach to be followed and walk in our outpatient clinic when the doors are open. So difference between advantage of this emergency room, that all emergency room doctors are trained on, and there is another point that Dr. Phillips didn't mention, that is like rapid induction protocols that not all emergency rooms are even aware of. So they're up to date with the protocols. So they feel very comfortable in using Suboxone. So that's why still much better for somebody suffering for opioid use disorder to go to this ER. Can you discuss the transition of the patient's handoff using the peer supports? I think I just did, right? We have a contract with HCA. They have access to ER. They have also access to the HCD inpatient psych pavilion for those that are admitted or Baker acted in a pavilion, and they'll literally warm hand of them to the clinic. If they are, again, after hours or on weekends, we have 24/7 service of peers.
Okay, well, this is all great. And we, you make a great point in that it would be nice to have a number of hospital emergency rooms that have the same services. And that's something to look forward to in the future, or to look forward to working toward in the future. I noticed that Dave, my boss, is zoomed in, and he doesn't have the opportunity to do too many more of these meetings. I hear that he's going into the private sector. I'm not quite sure, but I've heard a rumor to that effect. And Dave, would you like to say a couple of words to the group?
Al, thank you. No, I haven't announced specifically, and there's nothing totally locked down. I just, after 12 years of this job that I love so much, it's time for a new chapter. And especially when I became confident that my successor will be someone who will carry the mantle forward, someone who's going to continue with the same priorities. And, when you decide to leave something like this, you want to make sure that the office is in good hands, and it will be. And those good hands will include Al Johnson. So I'm excited about the days ahead, but I will miss this job. And the priority of mine that I'll miss doing the most is the Sober Homes Task Force, now called the Addiction Recovery Task Force, all the new names. But this was the signature issue for my administration for the past 12 years. And the fact that you're taking the time to meet on these calls continuously is just, so humbling. And I'm very grateful that you continue to do that. And we are the leader in the country now when it comes to cleaning up the drug treatment industry and reducing numbers of opioid overdose deaths, especially fentanyl. You look at the numbers, our county is doing it better than anyone in Florida, and I think anywhere else. So I don't know if I'll be able to be on the next meeting, and I'm hoping to give one final farewell, but I just wanted to say thank you and how much I appreciate all of you for giving up your time. I know you live busy lives. It's the number one priority for me and our office, and we made a real difference, but we didn't do it alone. It's because of all of you here, and I just want to say thank you. And although I'll be leaving the job in January, I'm not going away. I'll still be active in the community, and I'll still be involved with issues like this. So, I won't be disappearing. So I just want to say thank you in case I don't come back, but I do plan to come back for that one final meeting. So in the meantime, this is my tentative thank you and farewell.
Thank you, Dave. But for you, this would never have existed in the last eight plus years. So thank you. So before we close, are there any comments? And now I'm just going to meld people who are actively in the group and people who are public that are zooming in. I see John Hewlick, you have a hand up.
Just real quick, Al, thanks. Great presentations today. Could we just make sure that those PowerPoints are circulated?
Yes, Mary Ann's very good at getting those last minute PowerPoints and sending them out to the Good and Welfare. That it, John? Okay, I see Terrell, you have your hand up. Go ahead, Terrell.
Yes, hi, Al, how's it going? Hi, everybody. I joined late. I'm sorry. I had a conflict at the beginning of the meeting, but all the presentations were great. I just wanted to know if we're going to be discussing at all the legislative changes that we had talked about previously.
Well, it's probably going to be a brief discussion today, Terrell, because Dan, who is scheduled to make the presentation, he's injured and could not make it. What I want to say about Chapter 419 Florida statutes is that it not only violates the ADA and the FHA with a 1,200-foot spacing requirement, with a 500-foot spacing requirement from any single family zoned district, but it doesn't even include all group homes for people with disabilities. It was done way before the ADA and the FHA were, the bill was done way before it had been, those statutes had been analyzed. The case law, new law has come out, and we're trying to kick Florida into the 21st century. I plan, if we have a meeting in October, just to do this meaning the zoning issues and when it comes to community residences and recovery communities, because we have to change certain definitions. All of you should have the study that was done by Dan Lauber through the University of Florida department, the government department, through the University of Florida. We will have language no later than November. Any suggestions you may have, send them to me. We're not going to come up with anything perfect, but we can come up with something that's a lot better. And number one, that prevents lawsuits from having to happen to prove the point of discrimination through the Department of Justice. By the way, the next time we meet, we probably will have a representative from the Department of Justice in the ADA FHA area that's going to talk to us about how to take discrimination claims through the federal government. So it's going to be a really interesting and informative meeting on basically residences, zoning, and how do you have a path forward where communities don't get the pitchforks and the torches together because there's a 6-person or 8-person recovery residence that wants to open up in the community. And also to be able to educate zoning department folks, zoning boards and commissions, councils on what the law requires and the even way that it can be done across the state so that we can eliminate most of the discrimination, but also require either certification or Oxford House in order to increase the number of non-related adults living in a district instead of going through the case-by-case basis, trying to get it in a way that it's streamlined, it makes sense, it's not over saturation. And so I'm kind of rambling here, but Terrell, that's unfortunately, you were on most of the meeting, but did not know about Dan not being able to present. My plan is to actually have legislation that we can discuss to present to the legislature in the 25 session, which starts in March. That's the plan. Whether we have to wait till 26, that's another contingency. But I think we can do something this year. So stay tuned. Does that basically answer your question, Daryl?
It does. Thank you.
And I encourage everybody to read the study. It's long. You can read 10 pages a day and be done with it twice before the next task force meeting. So just saying, you've all gotten it. And if you need to go and get it and you haven't, it's on what danlauberlaw.com, I believe, is the site where you can look at the study that was completed in July. Okay, any other questions or comments before we break? Great presentations today. Thank you, Anne. Thank you, Courtney. It was awesome. Okay. Well, have a great rest of the week, everybody, and a great weekend. We'll be in touch as to when the next meeting is. Right now, it's scheduled for November 20th. If we have a zoning meeting earlier about 419, we'll let you know. Take care. Yeah.
Thanks, Al.
You bet.
Thank you, Al.
Take care.
Thank you.
Wait, come here. Let me end.